So I welcome you all to today's free recall session conducted by MMRCOG. I am Dr. Shweta Santalia, course director and founder of MMRCOG. So the purpose of today's session is not to cover any recall completely or uh, because that is practically not possible, but yes, the recalls do make a difference in your preparation in the final revision not because the same question is going to come in the exam, because at the end of the day, the recall are done by the students and students have given the exam. They can't recall every possible word written in the question. So first of all, the recall questions are incomplete, right? You all agree with me that some questions are incomplete, some questions are not written properly. You feel dilemma because what all words are written in the question. So recall question is not something you have to go like word to word as you do the book questions. It is different. How to handle them is different, and how to get benefited from them is different. That's why to just give you an insight about how you can boost your preparation at the end. You can give a good revision to important topics at the end. That's the purpose of recall session, recall discussion basically. So if you see, uh, you all must be knowing me. If somebody doesn't know, I'm Dr. Shweta Santalia, presently working in Barts NHS Trust, London. And this is my initial days photo, so I'm very fond of this photo. So these were within 3 days of my joining when I was struggling to find my feet here. So yes, you don't know what you will achieve by MRCOG, but sometimes you don't know what's written and where all heights you can reach. So you should progress in your life. And MRCOG is not only about passing the exam, but getting the knowledge, doing the right practice in your clinical area, and that gives you a satisfaction. So today's agenda is to discuss the recall Jan 2022 and how to start preparing for Jan 2024. I'm not going to go in detail of that because there are many introductory sessions already there in the YouTube channel. If anybody has uh, any doubt about how to go about preparation, they can always go through any of the introductory session and they will get a clear-cut idea about that. So our main purpose is how to handle the recall, how to get maximum benefit from the recall. So the people who have already given exam and who couldn't succeed, I know how it feels because you give a lot of hard work and you think you are trying hard, but whenever you are not able to succeed, always ask yourself a question: did you do enough? Did you really put enough effort? Was your strategy correct? What you're going to do differently this time? So it's very, very important. I wanted to conduct a session for people who couldn't succeed, but unfortunately didn't get time to do at the time of results. So just a brief idea about how to take things differently in this exam. Don't take it lightly. The exam is one thing I will always tell that if the recall questions are repeated in exam, that means the examiner know that we can't recall them properly and we can't answer them correctly. That's why it keep coming in exam. So this exam is very tricky and it needs a thorough knowledge. So never ever think that by superficial reading or superficial studying we can pass this exam. And not only about passing the exam, for getting benefited out of your knowledge of study of this material, it's very important that you read it very well and understand it very well. Shallow preparation is not going to work. Reading and question solving should be a balance. Follow the daily schedule, make a schedule and follow. Now in these revision days, how you are going to revise, how you are going to, what all topics you are going to revise in a day, how many modules you are going to revise in 7 days, like that, every revision should be shorter, is what your purpose of making schedule. And the time management is very, very important. EMQ solving is very, very important because that's the reason most of the time we can't make it. Practicing mocks make a difference, so do that. And revise and practice is must. So practice makes you perfect. So keep practicing. Don't lose hope. It always happen. Only you have to learn from it and do the things differently. So anybody who is preparing for JAN exam, this is the course, MRCOG course for JAN exam, which will give you an extensive preparation covering all the possible things and give you enough time with your busy schedule to prepare in a longer course of action. This is for July exam. The people who are looking for some support at the end for their final revision for the busy practitioner, this is the best plan where you get the self-study plan, where you get the recording of all GTG, TOG, and NICE guideline, and you get the EMQ sessions live, which is crash course. So that way it gives you maximum benefit. The course fee is minimal compared to the two courses. It's, if you add it, it's 800. You are getting it in Ramadan for 249. So let's start a recall discussion, how we are going to handle the questions and how we should approach the question. Even for Telegram group discussion, I told students that how to go. Actually, earlier I was helping students in preparing. I was posting recall and helping them revising the topic. But unfortunately, the schedule is very tight and not getting time for that. So I thought that doing this session will help you to understand how to discuss it in a group, because group make a difference. Many people, everybody's mind will remember different thing about a topic, which is an important point. So if you recollect all of that, if 10 people will gather one point, it will be 10 points from that topic which you will be able to revise. That's the benefit of group discussion, and which is must for this exams. This is must for the final revision where everything should be on tip of your tongue. So let's see how to approach the questions. Okay, anybody wants to read this question?
Yes, ma'am.
Yeah, go ahead, my dear.
Pregnant woman at 32 weeks sustained serious road traffic accident suspecting multiple spine fractures. What's the initial radiologic investigation according to NICE? Full body CT.
Very good. Full body CT. And if I ask you why not other options?
It
She's
will show
pregnant, so
all
why not MRI?
multiple.
Because any pregnant women, you don't want to do CT because of radiation risk, isn't it? So why not MRI? Because MRI is always our first. Don't forget your basics always, because now you remember it, but in exam when you read the option, maybe you will think, oh God, CT is unsafe in pregnancy, why not MRI? So that part, that doubt should come now itself rather than coming in the exam room. That's why I'm asking, why not MRI? MRI is safer than
Ma'am,
CT.
MRI, ma'am, in this option of MRI, it's only abdomen pelvis, it's not brain. Like, you won't be able to see about the
multiple
what is happening in
spine
the brain.
fractures.
And then
Spine.
again, spine, yes, yes.
Yes, very good. So MRI abdomen and pelvis is only related to pregnancy, or pelvis and abdomen is not enough, because you want to check the chest, you want to check the head, you want to check the bones. So for all that purposes, CT is a very good investigation. So you have to do full body CT. This is what written in the talk, and this that's why because the new talk has been come. Usually whenever a new talk will come, there will be questions from that, right? So now you got the question, you know that the question has been asked in exam from this talk. So what you should do, you should go open that talk, read all the tables, all the chart given in the talk, and revise the important point of that talk. How you will do that, I will show you. There is not much important charts in this talk. So what are the important points? This is a talk 2021 volume 4, trauma in pregnancy. So if you see, trauma in pregnancy is common. 6 to 8% of the pregnant women have some degree of trauma. 8% of the women in UK have some kind of domestic abuse. If their coma scale is 8 or less, they require the insertion of definitive airway. So sometime in SBA, they might ask you, at what Glasgow coma scale you need an insertion of definitive airway. So usually from talks, the SBAs come, right? So you should see the numbers, you should see some facts which might come in exam, and you should make a small note of that, all the possible points which you feel important, because everything you can't revise and remember from a talk. So take some important points, make a small note, and you just stick it either as sticky, or you make your notebook where you keep writing things whatever way, but make it small. Don't make it exhaustive that you can't revise it. So if you see the Glasgow Coma scale of 8 or less require insertion of definitive airways, and cervical spine injury can happen, so that you should keep in account. Other SBA could be that incision of chest drain during pregnancy will be 1 or 2 intercostal space higher than the usual 5th intercostal space. So there is an SBA saying that 3rd space, 5th space, 7th space, 9th space. So you will choose 3rd space. So this is different than non-pregnant patient. That's why they ask you that, are you aware what is different in trauma in pregnancy? So the difference is that chest drain should be on 3rd space, not the 5th space, because it should be 1 or 2 space higher, because in pregnancy the diaphragm push higher, right? So these kind of things, these kind of fact, you will never forget these kind of fact. Once you know that fact, you will never forget. This easy to remember. Numbers might be difficult to remember, but facts are easy to remember. So try to remember the facts well, because you might forget the number, but facts will be there with you always, and it will help in your clinical practice. Then they say that in major hemorrhage, in a trauma patient, you have to give plasma, platelet, and RBCs all in 1:1:1 ratio. They might ask you an SBA saying 1:2:4 or different ratios. But it's simple to remember that in major hemorrhage in trauma patient, you have to give 1:1:1. This is very, very important fact. Then they might ask you, which they have already asked, that what investigation you should do. So it should be whole body CT, and the radiation is 50 milligray, which is safer, which doesn't affect the baby in any sense. So it's safer. Though MRI is more safer, ultrasound is more safer, but if needed in emergency, you can do any investigation in a pregnant woman, because it is life saving. So pregnant women life is more important compared to the radiation exposure to the baby, is the basic fact which you should remember always in your practice. Like we do CTPA, we do CT chest, we do anything. Like a COVID lady will come, you will not hesitate doing CT chest. If a trauma lady will come, you will not hesitate doing a CT abdomen. So this is how you should understand the facts well. So your clinical understanding, clinical acumen improves simultaneously when you are preparing for exam. Don't take it like, oh, I have to rush for the SBA, remember it. No, your knowledge also should increase. That should be your uh, ultimate goal, to increase your knowledge, to do a confident practice in exam. Then there is, in trauma, definitely if she is more than 20 weeks pregnancy, then you will think about perimortem cesarean section. Perimortem cesarean section is another talk which we can't cover right now because we are covering trauma in pregnancy. So they say that 30% of the babies, approximately 30, between 22 to 23 weeks of gestation can survive. And if it is 24 beyond, then it will be 85% survival. So nowadays preterm survival is increasing, and they always are very fond of preterm questions about preterm survival, survival without neurological disability. All these things they always ask you in exam. So you should always remember that well. The questions, the percentage which are already asked in the exam, you should keep a note of that in a notebook, and don't forget that percentage at least, which are already asked, because there is high probability that will get repeated. Then they say regarding CTG monitoring for a trauma in pregnancy women can be discontinued after 4 hours if there is uterine activity less than 1 per 10 minutes. So they might give you a scenario saying when women came with trauma in pregnancy, she is 28 weeks or 30 weeks or whatsoever, and her contractions are now less than 1 per 10 minutes. So how long you're going to monitor her with CTG? So the practical point is you will discontinue it after 4 hours if there is no uterine activity, no bleeding, no pain. Because in trauma, you're worried about abruption. If there's no uterine activity, uterus relaxed, no bleeding, then no point in doing continuous CTG. So continuous CTG will be only for 4 hours. If she settles, then after that you can discontinue the CTG. This is also a practical point. So these are the things you should revise. These are the probable SBA from the talk which might come in exam. Whenever a question come from talk, there is probability of another question from that talk. So all possible tables and important point you can revise when you are revising the recalls. Hi Jasba, we are doing the Jan 2022 recall few question to understand how to solve recall question in
Hello, ma'am.
this
Assalamualaikum.
period.
Hello, ma'am.
Yes, my dear.
Ma'am, my name is Jazba. It's not Jazba. Sorry, it's
Sorry.
written.
Sorry,
Yeah.
Jasba. Sorry, my dear.
No, it's okay, ma'am. Thank you, ma'am.
Okay. Then, anybody wants to read this one? Yes? Come on, please volunteer and read.
Ma'am, I'll read. A
Yes,
18-year-old
go ahead.
primary amenorrhea, growth
Yes.
5 by 5, breast anesthesia 2 by 5, axillary pubic hair 2 by 5, a blind end vagina. Your diagnosis: Turner syndrome, DES, exposure, Swyer syndrome, Mayer-Rokitansky syndrome, complete androgen insensitivity. Okay,
Okay,
so
so what do you think?
it can't be complete, ma'am, because there is some axillary pubic hair is there, 2 by 5.
Hmm.
And breast is also,
What do you think? What comes in your mind when you see
mm,
a blind
ma'am,
end vagina?
estrogen exposure. Estrogen, okay, blind when vagina, maybe uh, MRCOG can be there,
Or
or
what are
androgen
the only two
insensitivity,
differential
partial or
diagnoses
complete.
for absent
Androgen
uterus?
insensitivity. Okay,
Two,
like
only
here
two
nothing has been
diagnoses.
mentioned, ma'am.
Pardon?
Ma'am, androgen insensitivity and MRKH.
Very good. So whenever you read a question, that topic should pop up in your mind. Whatever you read about, when you are reading primary amenorrhea, that topic should flash in your mind that I'm going to read about the detail of that topic now. So in your mind, it should come, right? And then you should read.
Yes.
I'm sure that this question is not complete because amenorrhea questions are at least 5 lines, and it is only 2 lines,
Yes.
so it is not complete. So your point here is not to fix an answer for this question. Your point here is to revise primary amenorrhea DD, which they always ask. Primary and secondary amenorrhea is very important topic for exam. And there is a YouTube recording in MRCOG if anybody wants to go through that to understand how to handle amenorrhea question. Now in amenorrhea, first and foremost important thing is to understand if there is secondary sexual characteristics or not. If secondary sexual characteristics are there, then you're sure that ovaries are working well. If secondary sexual characteristics are not there, that means the ovaries are absent, maybe Turner's, right? So if ovaries are there, secondary, primary amenorrhea, ovaries are there, blind and vagina means they want to tell. There must, I'm sure there must be more detail about absent uterus. Absent uterus, blind and vagina with good secondary sexual characteristic means your diagnosis goes to only two things. One is Mayer-Rokitansky-Kushner syndrome and other is androgen insensitivity syndrome. So how to differentiate these two? It should be clear in your mind, right? So how you will differentiate MRKH and androgen insensitivity? In MRKH, basically, it's a problem of anatomy. The uterus has not developed. It's a rudimentary horn. Ovaries are good, everything is good, but because of the anatomical problem, the uterus is absent. So blind vagina, vaginal dimple, and absent uterus is the characteristics of MRKH. But normal ovary, normal secondary sexual characteristics, she will be a full-grown female with all the features of female. Only thing is uterus is not there due to anatomical problem, the developmental embryological problem. So she is a full-blown female having everything like female, XX, but no uterus. Now in androgen insensitivity syndrome, it's androgen insensitivity. So it's an XY. It's an XY genotypically, but phenotypically, externally, it look like a female. So why it happens? Because XY is there, but the Y, because of Y, there is testosterone. But unfortunately, testosterone is not able to act on the genitals. So androgen insensitivity means androgen is not able to act on the genital. That's why the uterus has not developed. Because otherwise their uterus can't develop. Because the androgen can't work properly, that's why the male genital organ can't develop. So all in all, it's a midway. It's a male, but the androgen not acting, so it's looking like a female, and the testosterone is converting to estrogen. That's why the breast development is good. So what we used to read when I was in my residency long back, that it's a tall, beautiful female because of the good breast development, and because of the X, Y, it will be tall because of the testosterone converting to estrogen, good breast development, and it will be hairless because androgen can't act. So it's a hairless, tall, beautiful female, is what we used to remember like that. So there could be complete and partial androgen insensitivity again. Partial androgen insensitivity is more confusing because there will be sometimes small scrotum, some hypospadias and things like that, small penis. So it makes things more complicated. That's why usually in exam they ask you complete insensitivity and MRCHDD, which is very simple to make because here only breast will be 5 by 5. Otherwise there will be no hair and no uterus. So this is how you're going to differentiate these two things. Then it should come in your mind that what other could be the DD for a blind vaginal pouch or a septum. Sometimes it could be imperforated hymen. So how to differentiate that too? So if it is septum, then also they can say that it's a blind pouch because septum means it will look like a blind pouch, right? And if it is an intact hymen, it will also look like a pouch. So intact hymen will be bluish in color because it's a membrane and thin, and septum will be thick, so it will be pink in color. So these kind of things should pop up in your mind. Most commonly asked question in exam: imperforate hymen, vaginal septum, MRKH, and androgen insensitivity related to amenorrhea. And then the other important is PCOS and hypothalamic amenorrhea. So you should revise that when you are revising this question, not the finalizing the answer of this question, which is already incomplete. But your knowledge should be intense for this topic because this is very important from exam point of view. So this is how you should do the recall. And once you will do, like I told you to do from last to beforehand, because the latest question will cover the latest talk, latest popularity of question. So when you go back, you will realize that slowly, the number of questions for discussion are decreasing because it's the same repeat question. So now, like if I discuss Jan 2022, I'm discussing 150 questions, suppose. So in when I go back in July 2021, only 100 question or 50 questions would be worth discussing because other will be repeat the same topic. So everybody was panicking in the group that how can we revise 50 topic in a day? But fortunately, because it is a repeat, you don't have to repeat every topic every time because you have repeated that. Revise that topic. So don't go too fast and at the end don't gain anything. Do 20 question in a day. That will help you in gaining confidence in that 20 topic, and then go backwards and automatically the number of questions to discuss will be lesser and lesser. And one paper you'll find no question to discuss, maybe 5 or 10 questions extra. So it's not about you will excel in exam by fixing the answer for recall question, which is incomplete. It's about the revising the topic, getting clarity on that particular topic, revising that topic before exam, which will help you in giving your mind more clarity and freshness about that topic, which is most important and asked in the exam so commonly and more frequently. Okay, next question. Who wants to read this? Am I making sense? Are you all thinking that I'm talking sense?
Yes, ma'am.
Okay, go ahead then. Read this question.
Infant post-exposure prophylaxis after delivery, mother known HIV on cart from 20 week and two values less than 50. So it is low risk. Uh, it's low risk. So we'll choose A, zidovudine, for 2 weeks.
Is it low risk or very low risk?
Very low risk.
Very low. Mm.
Yes. So when the question come like this, this time they've asked you very low risk. So next exam they will ask you low risk. Then next exam they will ask you high risk. So they can ask you anything, right? So it's worth revising that table again because it's very low risk. So let us understand what is very low risk, what is low risk, and what is high risk, and what we are going to do in these three different scenarios. Right? So it's very important that we revise in that way. Revise the revise the chart, which is very, very important. That's what the purpose of doing revision of recall question before exam, to revise that particular topic, that part of topic, that chart of topic, which is very important to revise before exam. So very low risk means you need 2 weeks of zidovudine. Low risk means you need 4 weeks of zidovudine. High risk means you need combination, right? So what is very low risk? It should fulfill all the three criteria. The card should be more than 10 weeks. Two viral loads should be less than 50, 4 weeks apart, and less than 50 at or after 36 weeks. All three criteria fulfilled means you will give 2 weeks. If the criteria are not fulfilled, one of them are not fulfilled, like two are only fulfilled, then they will come in low risk. If the viral load is less than 50 after 36 weeks, or if the infant born prematurely less than 34 weeks and viral load is less than 50. So all in all, the viral load is less than 50, but you are not aware about how long she has taken the cart, or you don't have the two values apart which says less than 50, but at present it is less than 50. So still she is low risk. That's why you are giving 4 weeks of single agent therapy. And if it becomes high risk, which is more than 50, then you have to give the combination therapy. So this chart is worth revising when you're seeing this question in the recall discussion. Okay, next.
I'll read,
Anybody
ma'am.
can read. Please open your mic and feel free to read. Yeah.
Pregnant woman with breast lump which detected at 20 week. What is the initial imaging? Ultrasound. Ultrasound breast.
Very good. Some things are simple in exam. Now, these questions are coming since ages. When I gave my exam in 2018, at that time also this questions was coming in previous recall as it is. And now also it comes as it is. So not all questions are difficult and complicated and, think too much about. Your basic should be clear that ultrasound is the first investigation, and in pregnancy, anytime ultrasound is the first investigation. So we will do initial imaging, which is ultrasound. The similar kind of question they have asked about anomalous uterus. If you suspect anomalous uterus, what will be your initial imaging? Anyone?
3D 3D TBS.
Is that your initial imaging?
TVS is the
No,
first
ma'am,
one.
ultrasound. 2D
So
ultrasound.
that's what the play of word in exam. There is one thing called initial, there is one thing called definitive or most important or most conclusive, and there is one thing which is the final thing, where if you're confused with all the things, that is the final thing, like laparoscopy. If you do laparoscopy, yes, you can see with naked eyes what is going on. So if you see anomalous uterus, always the initial imaging will be 2D. If that doesn't give you a clue, then 3D. 3D is more important because it will give you a 3D view. So image, it is better than 2D for uh, anomalous uterus. And then MRI is the final thing, because if she's not sexually active, usually it will be in the young women and things like that. So MRI is the final imaging. And then the final thing is laparoscopy. So it's a practical thing. Once you understand this, once you have clarity in your mind, nobody can confuse you. What is the initial imaging? What is the definitive? What is the diagnosis of choice? These words, whenever you read any guideline, whenever you read any talk, these words should be imprinted in your mind that, okay, this is initial, this is the diagnosis of choice, and this is the definitive one, is what you should note down. If you want to revise it later, you can note down, or you write in your brain that this is how the question can come, because this is a very common way of RCOG asking you the question. Initial investigation of choice, always different. Initial is always different. Investigation of choice is different. Definitive sometime is different in different topic. So think simply, but things in the logarithm. Think clearly about the ladder of investigation is very, very important for any topic. And that's why they keep asking the same things again and again, because students keep confusing it again and again. So some questions are simple. Don't think that all the questions are very complicated in exam. So don't try to overthink and make the things wrong unnecessarily. Yes, go ahead. Who wants to read this? Come on, if you all are engaged with us, I want to listen different voices.
Yes, ma'am.
Yeah, go ahead. Please read.
A 22 weeks pregnant woman air travel from Paris to UK in order to celebrate birthday of her son. What's the preventive measure for venous thromboembolism? Graduated compression stocking.
Okay, are you sure about this answer?
Ma'am, nothing.
Okay, are you
Because
sure
Paris
about
Yes,
to
nothing?
UK,
yes, it's short
the,
travel, maybe nothing.
the
Yes.
flight travel time will be less than
Yes,
4
ma'am.
hours. So
It is
Yeah,
4. Okay.
Yes. So this is what in your first thought also you should have clarity that how to solve this kind of question. Now
yes, yes,
earlier they used to ask you like medium haul flight, long haul flight, short flight. Now they have become, now they are asking the same question again, but now they're asking you differently, Paris to UK. If you don't know how far the flight is from Paris to UK, you can't make this answer correct, right? So you have
yes,
to have
yes,
general, because they have asked like this, they might ask you about, now they have asked about France, they might ask you about Spain or surrounding area of UK. So maybe a geographical orientation a bit and
yeah,
understanding a bit of this will help you if they change the name, because they might not give again Paris, they might give something else, right?
yes,
So
yes,
this is how the same topics are asked again and again in a different way, putting the questions in a different way. So because this travel is approximately 2 hours or even lesser, if you go by flight, Paris will be less, I think 1 hour or less. So she doesn't need anything because it will be a short flight. So, but when you see this question again, you should revise your concept that for short haul, nothing is required. For medium to long haul flight lasting more than 4 hours, only stocking is enough. And if she's a high risk, then only she need low molecular weight heparin. So what are the high risk factors? Previous DVT, symptomatic thrombophilia like APLA or DVT and a heritable thrombophilia, morbid obesity, or medical problem such as nephrotic syndrome. So please remember it well. This small segment is very, very important, and travel in pregnancy questions are very, very important in exam. So the things which are again and again and again asked, you don't want to make them wrong, right? That is the key to success in exam, because the new topics are new for everyone. But the one who has done the homework well, one who has revised the most frequently asked question well, they will make less silly mistake and they will win the game, because it is a relative exam, percentile exam. There's no fixed number. So that's why you should always revise that segment of the guideline which is asked again and again in exam while solving recall, while discussing recall. So it will help you in your preparation. When you are talking about the DVT prophylaxis, always you should recall the contraindication for air travel, because that is also asked in exam earlier. When they can't do air travel, they should avoid air travel from 37 weeks in prime singleton and 32 weeks in multiple pregnancy. This is because they don't want them to deliver in flight, because the risk of delivery too, because that's the time they can deliver. For multiple pregnancy, preterm deliveries are common. That's why this protocol. And these are the other complication: anemia, hemoglobin less than 7.5. So this is how you should revise that topic, the important segment of that topic. Yes, come on, who wants to read this?
Yes, ma'am. A 60 years old lady with history of postmenopausal bleeding 4 months ago. Labs and scan done, all were normal. No, now again she came with postmenopausal bleeding. What's your initial management? Hysteroscopy.
Are you sure about your answer?
Let me read it again, please.
No problem. Go ahead. In exam, you can read the
Yes,
question twice. There is enough time for that.
exactly.
Whenever you lose the
So,
track, read it again. No problem. Go ahead.
so yes, in the first visit, the lab test was normal. For sure, they have, if they have done an ultrasound, then endometrial biopsy maybe? Sampling,
I'm
not
sure they
biopsy.
must have. I'm not sure what they have done. Basically, the questions to me looking is very incomplete because it's a recurrent
Yes,
postmenopausal bleeding. And
exactly.
then they
If
tell that lab and scan done all were normal. So if
mm,
scan was normal, lab and scan is normal, she doesn't need endometrial biopsy. If the scan shows more thickness of endometrium, then only you do the biopsy, right?
yes,
So I'm not sure, but she's coming with the recurrent symptom. And then they're asking again the initial management. So initial word is mentioned clearly for ultrasound. So definitely this question is unclear. Somebody has recalled it. Thank you to them, but unfortunately it's unclear. So you don't have to run behind, okay, what I will put in this? Shall I put TVS? Shall I put? If the
mm,
word initial will come, I will always put TVS. If the
okay,
word if recurrence of postmenopausal bleeding will come, I will always put hysteroscopy biopsy. Now, what is
yes,
endometrial biopsy and sampling? Both are same, right? So options and question both are not looking complete. That's all right. It's not
yeah,
our job to complete this question or answer or fix an answer for this. Our job
yeah,
is to revise this topic of ladder of investigation for postmenopausal bleeding to revise our clarity about how to handle a postmenopausal bleeding. So let's
yes,
revise. There is a TOG detecting endometrial cancer 2021 TOG. So if you see 2021 volume 3 volume 4 is coming in exam in 2022 Jan. So it's always a recent talk. They always give some question. This talk recording is also available in YouTube if somebody wants to go through. If you see here, what's the diagnostic pathway for endometrial cancer? So most effective diagnostic strategy for investigation is still controversial. But British Gynae Cancer Society says that TVS is the first line investigation, followed by biopsy with or without hysteroscopy if the endometrium is thickened. So when you will always do scan first and then you will do the biopsy if the thickness is more than 4 millimeter. Now biopsy to be done with hysteroscopy or people biopsy is enough. There is guideline for that as well. So it all should be very, very clear in your mind because this is always a happening topic in exam. And I'm sorry. And it's always asked in exam. So there is one stop postmenopausal bleeding clinic here in UK where they do everything in one go in single visit. So it will be more cost effective and more patient satisfactory. So TVS will be non-invasive. That's why it's always the first investigation, first line investigation, and it will help in triaging the women for further investigation. Character of not only the thickness, sometimes character of the endometrium will also tell you about the risk of malignancy. So it's not only thickness, but also the character of endometrium, which is important. So in exam, when you're reading the question, read carefully what thickness they have given. If the thickness is less, is there any abnormality in the character of the endometrium? So you have to do the biopsy, which is suspicious of malignancy. So you have to look for it. So this both the things are important, thickness as well as character of endometrium in the scan. Sometimes color Doppler could be of benefit if you are thinking about malignancy. So what point you have to remember? Premenopausal women, the endometrial thickness is not a good guide of endometrial cancer, but an endometrial thickness cutoff arbitrary of 11, more than 11, they have kept for thinking about evaluating them further. This is also a recall question which was used to come earlier in previous old recalls. So biopsy, endometrial biopsy is indicated if woman is presenting with postmenopausal bleeding, has a thickened endometrium on TVS. Hysteroscopy, so biopsy is needed if endometrium is thick or irregular looking or something like that. Hysteroscopy is indicated in these four situations. When is hysteroscopy needed? If there is persistent symptom. So if you see in the question, they have mentioned persistent symptom. So if that was the real question, that she has persistent symptom or suspicious ultrasound finding, in both ways you are going to do hysteroscopy biopsy. Thickened irregular endometrium with concerning feature, you will do hysteroscopy biopsy. Recurrent prolonged bleeding, you will do hysteroscopy biopsy. Random sampling, non-diagnostic, means you have done the pipil, which doesn't show you anything, then again you have to do hysteroscopy biopsy. So in a way, postmenopausal bleeding women, you can't leave her till you are very sure that it's not a problem. So you have to keep in mind when to do biopsy. First of all, do TVS, then when to do biopsy, and when to do hysteroscopy is the most important part of it. So most likely the word initial is wrong in the question. So if we take that, if we remove this initial word, then it should be hysteroscopy biopsy, but it should not be only hysteroscopy, it should be hysteroscopy biopsy. And there should be some mention of pipil biopsy or something, or scan finding how much is the thickness or character of endometrium in the question. So as I told you, this question is incomplete as well as the option, so leave it, but try to revise your basics of how you're going to diagnose postmenopausal bleeding women. MRI is useful mainly for preoperative age staging of endometrial cancer. So you'll do a biopsy, it will show cancer. Then you will do MRI preoperatively. So this is the 2-week wait referral with unexplained postmenopausal bleeding. What you will do, you'll do first TVS, you'll look for the thickness. If it is more than equal to 4 mm means 4 mm is also significant. If it is more than equal to 4 mm but not irregular, only biopsy. But if it is more than equal to 4 mm with irregularities or polyp, then directly hysteroscopy biopsy. So always in exam, they give you clarity in the question what they're talking about. If it is regular, do biopsy only. If it is irregular polyp or more than equal to 4, then you will do hysteroscopy. And if it is recurrent bleeding, we saw that we are going to do hysteroscopy with biopsy. So I think
Ma'am,
most
what about
likely the question.
ma'am, what
Yes,
about that 11 mm? In previous slide you told
that is
11
for
mm cutoff.
premenopausal women.
Okay,
This
okay,
is for
okay.
premenopausal women. They say that, sorry, not premenopausal, asymptomatic postmenopausal women, they say that there is no cutoff as such. For asymptomatic postmenopausal, they'll give you an incidental finding of thickness of endometrium. So ideally in
Okay.
postmenopausal women, it should be less than 4. If they are asymptomatic postmenopausal women and they give you an incidental finding of thickened endometrium, then more than equal to 11, you should take significantly. This is what the arbitrary cutoff they have given in the talk.
Okay.
So this table is very, very important. If it is regular, then only biopsy. If it is irregular, then straight away hysteroscopy biopsy. If inadequate sample in simple pipil biopsy, again it become high risk, and then you have to do the hysteroscopy biopsy. So if it is less than 4, you are fine. No need of doing anything. No biopsy required. So when the same thing, when you are discussing this question, your job is to discuss this algorithm. Your job is to revise this chart so that you understand that any question now come from this chart, I'm going to answer that correctly. So the purpose is to answer this chart correctly in exam, because this time they ask you this, the next time they will ask you this pathway, next time they will ask you this pathway. Anything they can ask from this chart, but they have proved the point that this chart is important for exam. So remember it well, is what your purpose of revising. Okay, next, who wants to read?
I'll read, ma'am.
Yeah, go ahead.
Patient present with urgency, frequency, and nocturia, has both urge and stress incontinence. What's the most appropriate management? So it's mixed. So they didn't say initial. Usually we treat the most predominant symptom, but he said both are there. We can choose urodynamic studies to see which one is the most prevalent.
D is the
It
answer,
is
ma'am. D.
initial.
Bladder training and PFM.
Can I answer?
Please let her discuss.
Yeah,
Don't
sorry,
jeopardize
sorry.
anybody's learning, even if you know the answer, please.
I'm
Even
just
if you know
thinking
the answer, it
loudly.
can be wrong because question can be incomplete. So here we are discussing, we are
Yes,
not fixing
ma'am.
any answer.
Yes,
So
ma'am.
please be patient. Yes. Who was
So
reading? Please
initial,
go ahead.
yeah. So initially, if it says initial management, we can choose the bladder training and the pelvic floor muscle training. That is like D. But most appropriate management is for me urodynamic to see which is the predominant symptom of the urge or the stress.
I'm sorry, what's your name? Sahala? Is it Sahala?
Asma.
Asma. Asma, my dear. The predominant symptom, is it urge or stress incontinence? That is according to the history. That is not
Yeah.
according to urodynamics.
Okay.
That is according to patient history. So, as I told you, recall question incomplete, words are incomplete. I don't know what was it most appropriate or initial or what kind of management, I don't know. But it's always by the symptoms. The patient will tell you that urge incontinence is bothering me more or stress incontinence is bothering me more, like that. So it's not by urodynamics. It's by the patient's symptom. What is the most predominant symptom you want to treat first? Now here, as I understand, somebody has recalled and they want to tell you that the patient was having both the symptoms. So how you are going to treat her? So
Treat both. Bladder
so you
training
have to treat both,
for the
right?
urge
And
and pelvic floor muscle
if
for stress. Yeah.
if in question they give you clearly that she has predominantly urge incontinence is bothering her or stress incontinence is bothering her, then and they ask you about initial management,
We choose one of
then
them.
what you will choose.
Bladder training for urgency and pelvic floor muscle for the stress. Yeah.
But don't you think that if she has both, you have to give her both the non-invasive treatment? Like if I have urge incontinence as well as stress incontinence, and urge incontinence is bothering me more, stress is not bothering me more, but I have stress, right? I have
Yeah.
both.
Yeah.
So will you
So
not tell me to do PFMT as well?
yeah, sure. Because it is
You
there. It's
will,
bothering
right?
her.
If
Yeah.
somebody is coming to you with both the symptoms, automatically your first plan will be to treat both. And
Yeah.
then if it doesn't improve, you want to go for surgery, then you're worried about the predominant thing you want to treat by surgery. Because like supposedly I have urge and stress incontinence and you treated me with bladder retraining and PFMT, and my main symptom is urge incontinence, which is bothering me more. I do have stress incontinence, I did both. So, because urge is my predominant symptom, next you will think about referring me to MDT, urodynamics, and then botulinum toxin, right?
Sorry, ma'am, there is echoes.
Can you please close, all of you, please close your mic? I don't know what happened suddenly. Can all of you please close your mic? Yeah, I know, voice, I can hear my voice. I'm sorry. Is it better now?
Yes, ma'am.
Yes.
So because somebody's mic was open, that's why it was echoing, I think. So that is what I'm telling, that if anybody come to you with mixed incontinence, obviously you will give them the basic treatment for both. Furthermore, if her urge incontinence is her main problem, for surgical management, I will go for botulinum toxin, not the tape surgery or stress incontinence surgery, because that is not bothering her. She's okay with that. You get my point, what I'm trying to tell you all.
Yes, ma'am.
But definitely, if she has mixed incontinence, you're going to treat her with both training as well as PFMT. Because even if it is not bothering her now, it can bother her later, and you don't want it to become more worse. If something is already there, you have to educate her. You have to, and this is not something invasive that you will tell her that, okay, if you wish and will, if you consent, then we will do it. No, it's just simple exercise which she need. Am I making sense?
Yes, ma'am.
Please don't open the mic if you don't want to speak, because then the recording will be really difficult for people to listen, please. If you want to speak, you're most welcome to open. But if you're not speaking, please keep it close. Okay, so this is what the point I wanted to make, right? So always understand some things very clearly, that what they're trying to ask you. But anybody who is having mixed incontinence, the answer will always be both of this. Whatever predominant they have, it's all right. You have to treat both of that. Predominant
Okay,
is mainly for the next step, that for which you will go extra surgical approach you will take, and furthermore, and then the question is very clear in exam, don't worry. Once you know the facts, once you read the question, you automatically get that where the examiner is taking you, and you automatically get the right answer. So if you are getting an urge and mixed incontinence or stress incontinence question, you should always have the clarity. You should revise in your mind that, okay, what I know about OAB, how I'm going to manage. First of all, you have to do the lifestyle thing. If BMI is more than 30, lose weight, reduce the caffeine. So first of all, lifestyle. If that doesn't work, then what? Medical management means the training, obviously, and after that, lifestyle will also lifestyle and bladder retraining, and then you will go for medical. In medical, the lowest cost first. If that doesn't work, what to do? Refer her to MDT. What MDT will do? Botulinum toxin. But before that, they have to do urodynamics. Then what next? Percutaneous sacral nerve. Then what next? These are the other options. So it should come pop up in your mind that not only this question, whatever questions of urgent continence management will come in exam, how I'm going to manage, what I will choose. It should be tick, 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 come in your brain, that lifestyle, bladder retraining, medical, botulinum toxin, sacral nerve. So you don't have to revise this before exam, because by the time you reach giving the exam point, this simple things will be imprinted in your brain so clearly that you don't have to revise this before exam. That's the purpose of final revision. That's the purpose of important topic revision before exam. Okay, next, who wants to read this?
Yes, ma'am. Patient has voiding difficulties. What's your initial management? Urodynamic measure costs. I don't know if measuring post residual urine it's regarded as a management. I will choose measure post residual urine on scan.
Very good, my dear. So anybody who has voiding difficulty, if somebody comes to your clinic or in the ward saying that I can't pass urine, I'm having abdominal pain and I can't pass urine or whatsoever, you are thinking that she's having voiding difficulty, like post-operative patient sometime, the anterior repair you have done for cystocele and patient can't void the urine now or finding it difficult. So first of all, you have to document that she's having voiding problem and she has some residual urine in her bladder, right? This is what first point. First of all, confirm the voiding difficulty by seeing how much residual volume she has. How you're going to do that? There are two ways of doing that. Either you do a scan or you do a catheter. Now, if you do a catheter, that is invasive, that can introduce infection in the bladder. So definitely always non-invasive first. So you'll do scan, check the post-residual urine, and if you find it positive, what you're going to do? Okay, I did the scan and I found that there is a residual volume of 150. What I'm going to do?
Maybe I want to check one more just to be sure that's significant residual urine, and then try by the right micturition technique and pelvic floor training.
No, here we are not talking about management part of you. Here we are talking about the investigation, making our investigation confirm that she is having voiding difficulty. So how to
Yeah,
find
then
out
will be
that? So you did the
then
scan,
will
you
be
found
your
that volume is 150. What next?
urodynamic.
Urodynamics.
No. No. Simple thing first. Yes, you will do urodynamics before offering her surgery if she has urodynamic voiding difficulty. I totally agree with your point. But here I'm trying to ask that if you see in scan residual urine, you always
Yes.
have to catheterize her and see is your finding correct. If scan shows negative, no need of further steps. Like if scan shows only 20, 50 ml, less than 100 ml, no worries. But if it is
Yeah.
showing positive, they say that you should confirm it by putting a catheter and seeing how much actually it is. Because scan is not 100% correct. It's not 3D scan, it's a 2D scan, right? The
Yes.
the measuring of residual urine is 2D scan, and bladder is a 3D structure. It's a pouch. So you
Yeah.
always have to confirm that by putting the catheter and measuring how much urine you got as a residual urine.
Yes.
So these are the simple things they always ask you in exam, which you should have clarity. But I totally agree that your initial management will be to check for residual urine. Okay, next. Who wants to read this?
Ma'am, may I?
Yeah, go ahead.
What's the best suturing technique for internal anal sphincter in a perineal tear? So it's end to end.
Okay. Can you tell me when you will use overlapping?
Overlapping is when there is a complete tear of internal anal sphincter. So at that point, you can do an overlapping. If it is a partial tear of internal, no. Internal anal sphincter is always end to end.
Very good. Yes, go ahead with the
Internal
extra
anal sphincter
facts
is
you were
always end
telling
to
me.
end.
Yes, and what about external?
It's for external anal sphincter that if it is a partial tear, then you do end to end, and if it is complete tear, then you can do overlapping or end to end.
Okay, very good. So whenever you see a question of internal anal sphincter or external anal sphincter injury, you should revise about the technique and you should revise about the suture. So what suture you will use?
Vitral 30. Sorry,
Is that
PDS,
your
PDS
first
30,
choice?
PDS 30.
PDS 30 is your first choice for a sphincter. What is the first choice
Yes,
for anal mucosa?
Vitral 30.
Very good. Now, what is the technique for anal mucosa?
It is continuous. Continuous.
Always continuous?
Yes, ma'am. Continuous.
Okay, let's see. So now you're clear that internal anal sphincter is always end to end. The question is very much clear that best suturing method. So you choose end to end. It's internal anal sphincter. No other thing is there. So if you see the mucosa, it could be either continuous or interrupted. And your first choice is 30 polygalactin, which is Vicryl. For internal anal sphincter, it could be interrupted or matrix suture end to end. For external end to end, or sometimes the overlap. The suture could be 30 PDS, which is our first choice. So 30 you remember. So 30 PDS for the sphincter and 30 Vicryl or polygalactin for the mucosa. So remember 30 well. And then if they don't give you 30 PDS for the sphincter, then your second choice will be 20 polyglectin, which is Y. So please, please, please remember it well. This is very simple
সকালে
thing and
পেয়ে
it's
যাবো।
always asked in exam.
না না, আমি শনি রবি শুধু সকালে বসি।
Okay, so this is very, very important. It's a very small guideline and it's very, very important. And recently in exam, they ask you about the delivery method, that if she has previous tear, how she can deliver. So definitely when you're revising, you should revise that part as well. Okay, next, who wants to read this? Come on, it's a simple statistics question. Don't be scared. Nobody wants to read, then we'll end
Ma'am,
the
should I read?
session.
Can I read?
Ma'am,
Okay.
Go ahead.
Mode of delivery data was collected from labor ward records of local trust, then analyzed. What type of data it was? Nominal.
What is the nominal data?
Nominal is the by name. The data that is by name.
Yes, very good. So mode of delivery is what? It's a name, right?
Like a
Either it
normal
could be
delivery or
vaginal
cesarean.
or
Yeah.
cesarean or instrumental
Yeah.
delivery or whatsoever. So it's a name, right?
Yeah.
So that's why it
Yes.
is nominal. So
Nominal.
type of data, they always ask you in exam. It's a simple thing. It's not difficult to do and you can easily do that. So at least simple statistics, you should be very clear about, which you can do right in exam easily. So if you see the type of data, data can be of two types, either qualitative or quantitative. In quality, it could be either name or order. Order means mild, moderate, severe. There's no fixed thing like mild, moderate, severe, but it's in a grade, right? So that become the order. Low, medium, high. Her social status is low. Her social status is medium or high. There's no fixed criteria for that, that this much money will make her this like that. So it's in a order will become ordinal data. Nominal means any name like gender, male, female, hair color, ethnicity, or like mode of delivery, like anything by name will become nominal. We understood order, that these two are qualitative data. Then in quantity, there could be discrete or continuous data. Continuous, it's in decimals, like 10, 10.1, 10.2, 10.5, 11, like that. Discrete means in numbers, like number of student cannot be 1.5, either it will be 1 or 2. Number of workers, whatever you're counting in numbers, it can't be in decimals, like person can't be in decimals. So that become a, or yes or no, like she delivered vaginally or not. So it cannot be 1.5, either she delivered vaginally or she didn't deliver vaginally. So it will be a discrete data. So that is discrete data. And continuous is where you can uh, do it in decimal, like height, weight, uh, things like that. So this is very important and simple fact to understand. Once you understand that, you can easily differentiate qualitative and quantitative data, discrete and continuous. Okay, next, who wants to read this?
I'll read, ma'am.
Yeah, go ahead.
Patient had twin pregnancy. What is the appropriate time for GPS screening? 32 to 34 week. 32 to 34 week. Usually we do it 3 weeks earlier, right? 2 to 3 weeks earlier from the singleton. pregnancy, and twin we do it 32 week. So I think it's C.
When you do for singleton pregnancy?
34 week. 3
Is it
weeks
34?
before term.
And from where you take the swab?
Lower vaginal and anorectal.
Okay. So whenever these kind of questions come in exam, always remember your facts before going for the options. Why? Because once you see the option 32, 33, all 34 in exam stress, everything will become confusing. So always these kind of questions first memorize in your brain. Okay, they are asking me about twin pregnancy GBS screening. Okay, what is the singleton pregnancy GBS screening? And twin is 3 weeks earlier. So for singleton it is 35 weeks. So twin it will become 32 weeks. So that information first gather in your brain and then go and read the option. So you will not do it wrong. That is the best way of doing it. So if you see, and then they have given so close option like 32 to 34 and 32 to 35. So you should remember well that the range is 35 to 37 and 3 to 5 weeks prior will become 32 to 34. This is how they confuse you in exam. This is very close if this is correct. If this was there in the exam. So it's very close. So that's what this kind of question, the number questions, the week of gestation, things like that. You should always memorize it in your brain before jumping and reading the options. So you will never make it wrong. Because once you read it in exam stress, in spite of knowing you can make it wrong, which is not at all pardonable. Because if you know something so well and if you do that in wrong in exam, saying that, oh God, I did so many silly mistake, then all your 6 month, 9 month, 1 year hard work went in vain because of this silly things. So the right tactics, the right strategy for exam giving is also very, very important. The right way of reading the question, gathering the question, and then when to think about answer, when to go through options, how to exclude the close options are very, very important. Okay, so this is what then the antibiotic, they always ask you about antibiotic. So you should revise that benzyl penicillin, but if it is allergic to penicillin, then cephalosporin, severe allergy, then vancomycin. So these are some common question always asked in exam. Now in recent exam, they ask about patient having syphilis and she is allergic to penicillin or something like that, severe allergy. So what's the alternative? So always you should remember the second choice as well. It's not like first choice. You should remember the allergy thing well. Okay, this is the last question. Who wants to read this? This is regarding surgical site infection because the question is incomplete. The most important preventive measure before surgery to prevent surgical site infection, basically. So what do you think? What is the right answer? If everybody can write in their chat.
D, ma'am.
Take shower. Yes. So take shower is what is recommended. Recent talk of SSI has come, which is very, very important. It's 2021 again, is the volume 3. So as I told you, for 2022 exam, third, fourth volume, many talk has been asked question, though we have covered only few questions. And we saw that 3 talk questions have come. So recent talks are always important, which you should go through well and remember it well. This recording is also in YouTube if somebody wants to go through in MRCOG YouTube channel. So preoperative showering is useful. Clipper in place of shaver is useful, but hair removal is not must, no need of hair removal for everybody. Single dose of IV antibiotic is useful. Then the skin preparation first choice is alcohol-based solution. This is also the exam question, that what is your first choice? So alcohol-based solution of chlorhexidine is your first choice. Then the recommended antibiotic, which is very, very important. Sometimes they will give you cefazolin, sometimes it won't be there. So what to choose? Kefenmet. Sometimes they will give you penicillin allergy. So what to choose? Clendagenta. So these things should be clear in your mind. This chart is very, very, very important. And when we gave exam, we were not having this talk, and it was very difficult for us to gather information for every bit and corner. But thankfully, you have this talk, and the questions now will come from this talk only. And then in recent exam, they asked about cesarean section, which is the most common organism causing wound infection. So it's Staph aureus. So these kind of things you should revise when you are discussing these recalls. All the most commonly asked question from that topic, all the charts, all the tables, all the possible things coming in your mind, giving the information to each other is the best way of solving the recall and discussing the recall. So that was the purpose of this session today, to help you understand how to go about recall discussion. And if anybody is interested in joining the recall course, it covers from 19 till 22, and the fee is £99. So if anybody is interested, they can contact us. So that's all. If you need guidance, you can join us and we can help you in succeeding. Thank you so much for attending today.
Thank you, ma'am.
If anybody looking for mocks, you can check the website. There are many things. If you're looking for particular module or mock or anything, you can always go through website and understand your personalized plan, what you need, what kind of help you need from us. Thank you so much. So all the best for your exam. I hope it gives you clarity how to solve recall. And if anybody is interested in solving it, they can start discussing in the group. And I can help whenever you have a doubt in any algorithm, you can tag me and I can help in the solving for sure and try to give you clarity.
Thank you, ma'am.
That's it for today. Thank you so much for your evening with me. Bye bye. Have a good evening and enjoy.